I think what we're going to do is we do have some slides and that they can show, but maybe we'll start kind of the reverse. Start with some of your questions. If you have some burning questions for the dentists, we'll start with that first. So are there questions? Yeah, we'll start over here with Marcos.
Good morning. I have a question about the needle on dental.
Whenever you ask a questions, please state your name and where
I'm sorry. My name is Marcos Cardozo, and I'm from Florida, but originally from Brazil. I was in Brazil 10 years ago, and I went to a dental procedure and take care of some problems. Instead, they use the needle, they use a gel as an anesthesia. So I'm kind of surprised why I've been seeing needles as an anesthesia.
I wish it was so simple that you can use gel for everything. You cannot. And yes, we do use gel to substitute for simple things. You can put the gel, which has local anesthetic, on the skin. So it anesthetizes locally the skin. So for example, not every place can have an anesthesiologist to make sure the child is asleep before they start a simple IV. But if you put the gel, cover it with a tegaderm for about an hour and take it off, the skin is numb and you can insert an IV. This is not a solution that substitute for major procedure like you do teeth extraction, a major abdominal surgery, and so on. But yes, we use a gel for simple, straightforward procedures, but not a substitute to much larger extent surgeries.
I understand that, but my question was in the dental, like a simple procedure, like extract the tooth or do some cleaning, put the gel inside the FOP patient.
Excellent question, and I defer it to the world expert in dental care, two of them that sit next to me, and they can answer you.
Simple procedure is always relative. So when you say simple procedure, for example, an extraction, in a child where your tooth is exfoliating, yes, it could be simple. However, if you're wanting to extract a back molar in a permanent permanent dentition where you have an older individual, it's no longer simple. It's a much more complex procedure where you require a completely different anesthesia. So it depends on the extent of freezing that you're needing as to the kind of anesthesia that you're going to do. It's quite variable with respect to what you need to do. So if it's a child that has got a tooth that is just about to come out, oftentimes just the gel is all that is sufficient. If you're needing to extract or even do a filling on a tooth in the bottom, it's a very different procedure than doing a filling or an extraction on a tooth in the top, requiring very different kind of anesthesia.
Thank you.
Get you the mic.
I have a question. Adam recently, his jaw has locked and he's on minced food. He's finding a lot of times he gets stuff stuck back where I can't get it. And he's having flare-ups still in the jaw. Is there a trick that I can do or use to help loosen the stuff that gets, he says it feels like it's stuck back in his throat. So is there a trick that you know of that can help loosen that stuff and get it to go down?
That's a kind of a loaded question in terms of a trick to get back there. It really is dependent on the extent of neck mobility in terms of how many teeth you have in the mouth when you are completely closed down. What's the ability of getting back to that area? Are there gadgets that you can help to get back there? Bottom line is when you have the teeth where you are completely closed down and you have a full dentition at the back, I'm actually recommending that you remove some of those back teeth so that you can actually have a access opening so that you can put food in there, so that you can take tablets, so that you do have an access where if you need to throw up, you can throw up through, because that's a huge issue if you're completely closed down and you get sick and you're throwing up. If you aspirate that, it can be really serious. So you have to think about the risk-benefit ratio of what it is in terms of preparing that individual for possibilities like that. So if you're in that circumstance, if you can, a trick is possibly having something like a very small instruments that can get back for you, or if you have a water pick, for example, that you can get back there. But again, it depends on the individual's ability to actually rinse or swallow or expectorate. And so those are serious issues. And if you're having that on an ongoing basis, then you actually have to have a look at what can we do preemptively as a preventive nature to help that person have a much better quality of life.
Thank you.
Just to add, I remember that as Dr. Clive Friedman stated, the issue is food that goes in and food that stucks in and food that needs to come out. So it's a challenging when you have difficulty to close the mouth or the mouth is shut in various levels. And clearly it enlightened me when on a Christmas day, I received a Christmas card. And being a Jewish person, usually I don't get Christmas card. And this was a Christmas card from a young lady from Europe that had surgery at Jefferson, teeth extraction. And she said, Dr. Grunwald, I want to thank you and the team and Dr. Nussbaum because it was one of my happiest Christmas recently. I could enjoy solid food and a steak after the teeth extraction and access, as Clive Friedman stated. So it has more than just the extractions, the excess, the food that it stocks and beyond. And Clive mentioned this morning, and we didn't recommend as a routine to do the molar tooth extraction, but if we hear more from the community, should it be a recommendation, a consideration, you're 100% correct. Food that's there, food that is stuck, and food that needs to come out. And definitely, and as a response, this type of surgery needs general anesthesia because usually it's more the elderly person, and if the tooth has an infection, inflammation, abscess, or even not, but it's stuck and needs significant effort to get it out, and usually it's done by the oral maxillofacial surgeons.
If I can add to that comment, oftentimes if you've got food back there and you can't get it out, it is a nidus or a what I mean by that, it is a it creates an area which encourages the formation of inflammation. So if you've got food stuck underneath the gum, you get inflammation. You know what happens when you have chronic inflammation anywhere in the body with FOP. It then is an indicator for, or possible for a flare-up. And that can be a huge issue. So making sure that you have a constant environment that is clean and you don't have the possibility of inflammation is really important.
Just a note, Professor Eric, I think the session about the toolkit started at 9:40, and I think they're waiting for you. and again, this is Eric Schneider, and please connect with him. And if you need special tools, if you go out, it's one of the room on our left or right. Mary can help him. to go to the toolbox session. Okay.
I have a question. I remember a patient from Sweden with locked jaws, and they've made a bigger hole in here between the teeth, so they file down the teeth, so the teeth got a little bit shorter, so he was able to get food in easier. And I don't know how that works, if you just can make the teeth a little bit shorter but not go down to the nerves instead of doing surgery.
That is a very interesting question with respect to I think what you're asking is it possible to actually grind the teeth down in the front to make an opening in the front instead of removing teeth under general anesthesia? So the answer to that question, it is perfectly possible to do so. When doing that, you can do that sometimes even without local anesthesia, and if you do it slow enough, what ends up happening is you slowly grind down the teeth, and then it allows for the dentine of the teeth, because as you grind it down, you're opening up. Imagine you have, the tooth is made up of thousands and thousands of tubules. As you grind down the enamel on your tooth, you're exposing that tooth and you're exposing those tubules. And what happens over time is those tubules get closed up and you no longer have sensitivity. So that if you do that over time, you can actually remove some of the tooth structure and gradually be able to get an opening. So if your dentition is such that it is a possibility, it's absolutely something to think about. And this is what one needs to have a look at in terms of individuals with FOP, is out-of-the-box thinking. What can we do? So if you have a dentition where the teeth are in what we call a very deep bite, and you don't have a lot of, and it's really complex, then that's no longer a possibility. If your teeth are not overlapping dramatically, then it becomes much more of a possibility. So it's very individually dependent, but again, it takes that thinking outside of the box. What are the possibilities that we can do? And furthermore, if you're doing that, there are materials that we can do to actually decrease the sensitivity as we do that. So you can up the ante, so to speak, and get it done a little faster. It's a great question.
The biggest thing with that is the sensitivity, because everyone's level of sensitivity. You may be more sensitive than the next person than the next. And so that sensitivity that he's referring to is the biggest reason why we don't just necessarily jump to that, because that sounds like an easy fix, but based on everybody's individual needs, it's not always a possibility. But it is certainly something to think about. Just know that there's, because of the tubules, there is that high incidence or high likability of getting the sensitivity.
I've been running with the mic and I don't use it. Sometimes it can be so very little that make a huge difference. Mm-hmm. Mm-hmm. So, and I think it can be good to just think of it. Mm-hmm. When you and me, we maybe not think that's a huge difference, but in a FOP patient, it can be, it can be a huge difference, just the tiny.
Right, but again, it depends on the patient's bite. If they have a steep overbite and you do that, it's not, we haven't really gained a lot from it, so it's individualized.
Other dental questions?
So I'm not seeing a lot of questions, but I have a question for you. And anyone can answer this question. Why do you brush and floss your teeth?
To prevent inflammation and to keep your gums healthy.
To prevent inflammation and to keep your gums healthy. Tell me more. What do you mean?
Well, if you're flossing,
so you're brushing and flossing every day?
If you're brushing, you're getting the food off. But if you're flossing, you're make sure between your teeth and your gums, there's nothing sitting there. and you don't have food sitting there, you don't have growth of bacteria, you don't have inflammation and toothache and all the bad things that could happen afterwards.
So you're partially correct, and if I can share with you the reason why you're actually really brushing and flossing every day, it might make sense to you as to why you need to do it. And a lot of individuals are not really familiar as to why we actually need to brush and floss. So what actually happens on a daily basis is that every 24 hours, our mouth is creating what's called a pellicle, and that pellicle is made up of proteins that attaches to the tooth structure. Bacteria attach to that pellicle. In order for you to have disease, it's the attachment of the bacteria to the pellicle that enables that bacteria to then use any kind of food particle to create the acid and enzymes, poisons that create bacteria. The brushing and flossing actually results in perturbation of the bacteria. Perturbation meaning the disruption of the bacteria on the pellicle. So when you get disruption of the bacteria on that pellicle, it no longer is able to produce the acid or enzymes. So if you're actually disrupting that on a daily basis, you're actually preventing the disease that you're talking about. And so the real reason for brushing, flossing on a daily basis, apart from removing excess food particles, is actually the disruption of the bacteria attachment to the pellicle.
I think my question is just going back to the basics. I think we all have FOP family members of different stages, advanced, or my daughter's a variant, but we all have the same need of proper dental care. So just like basics, our basic cleaning that we do twice a year, the basic meetings of the appointments with the dentist, and these guidelines, I mean, I think I want to know what is just the basic care that an FOP patient of any level should be getting? And is it in these guidelines that, God willing, I will print out and give it to my dentist the day before her appointment? But I think I just want to, maybe we should just review. What is the basic dental care that an FOP patient should have, and what should be concerned? You know, because it might say, oh, this is just a basic cleaning. But we don't know. Maybe they'll do something. And so I just want to know that.
I think that is also a great question, and with the recent guidelines that was updated, and the basic care is actually detailed based on age. So if you look at the recent guidelines, it'll actually tell you what that basic care is with respect to age, in terms of what is recommended from an ongoing care basis. So the recent guidelines will have the details of that for you. So please, if you have a look at that, or if you have any questions related to it, don't hesitate. If I can make a recommendation to anyone in the audience, is instead of asking your dentist to go to the IFOPA website and reading the guidelines, if you actually run off the dental aspects and the anesthesia aspects of it, the day before you're ready for an appointment, run it off, take it into the dentist, the hygienist, give it to them and say, before I come in tomorrow, I would like you to please read these guidelines. If you have any questions, please don't hesitate to contact myself, Dr. Grunwald, Dr. Crow, and they will be delighted to answer any of those questions. Don't expect your professional, your dentist, to actually go to the website to read any of that stuff. And in many offices, it's not the dentist who's going to be seeing you first. It is the receptionist, or it is the hygienist who's going to be seeing you, and they need to be able to have read that information prior to as well. If you make it easy for them to do it, then it's more likely that they can do it. And I'll tell you a little story that I think that I really enjoy, that I've loved, is that I have one mom who asked the dentist to actually contact me. The dentist did not contact me. She contacted me via WhatsApp. She went into the dentist. She held the phone. She gave the phone to the dentist, said, "You're not touching my child until you speak with Dr. Friedman." And he had no choice. He had to speak to me because she had me on WhatsApp, and he then spoke to me and then was able to then go ahead, because she said, please contact him before you touch my child. He did not. She then followed up. So if you advocate for yourself that way, you're going to find that you have the professional who will begin to listen.
Something I like to do is I like to have the patients come in every 3 months. That way I'm checking the gums, I'm checking the inflammation, I'm checking for caries. And the first time I see the patients, even if they are fairly locked closed, I still measure what little bit of opening I do have on them. Or if it's a lot, I measure that, so that over time, each time they come in, I've got a good eye on what's going on. And there's been many times where I've been able to intervene, get a hold of Dr. Grunwald and say, I think we need to take this person to the OR. There's more going on here than just, the average thing. So it's more of a preventative thing, which is what he's saying as well, Dr. Friedman. Prevention is so key, and it's so important. And some of them balk at me and say they're busy, they don't want to come in every 3 months. Why can't they just come in every 6 months? But I found so much more benefit to the patient when we're in the mouth helping them clean, because they don't always have access, and a lot of them, based on again, we have to think outside the box, their restrictions or what have you, they can't always get in there and clean. They don't always want the caregiver in there. One of them I have just insists on drinking apple juice every time she turns around. So there's things that we have to work around, and habits that the patients have, that if I feel more comfortable having my eyes on them and in their mouth every 3 months, just to try to prevent things. I think it's key.
Just to reiterate, although it's a dental oral maxillofacial session, the anesthesia component, if your child or yourself need to go through the process, is critical. Many years ago, 4 a.m. in the morning, baby was born with congenital anomaly. Surgeon and myself about to go to the operating room, and the surgeon, who is a seasoned surgeon, turns around, looked at the young parents and said, I just want to tell you one thing. I'm a seasoned, many years, pediatric surgeon. I've seen many surgeries. So there is big surgery, there is small surgery, there is no small anesthesia. And he was right. So the idea that you may need a surgical procedure that involves an anesthesiologist behooves you, and make sure that the anesthesiologist will not touch you or your child before he or she have a plan, saw you the day before surgery or a week or whatever it takes, and then we should talk, make sure that we agree on the anesthesia plan. It's very important.
We're very gifted to have you here. And I think this is my first gathering, and I am overwhelmed with the connection to the professional community. But in the general population, are dentists or anesthesiologists, your peers, eager to know about us or know about your guidelines, to know about the cautious way you have to do things? I was just curious, I know I'll be advocate for my child, but there's many, many people, and I know your outreach, but I'm just saying in a general sense, do you feel that your peers are eager to connect to you, to learn about these new guidelines?
Well, actually, I learned something from Dr. Friedman last year in the family gatherings, where that very question was asked to us over and over. And he said, if they're not, find someone else. And I actually recommend people with that now, but he can speak more about that. But it's true. It's very true.
I hate to admit that not all professionals are eager to learn. And many of the professionals say, are, I would call it, know-it-all. And so you tell them that this is what's needed, this A, B, C, D, E, and please contact, and they say, yeah, I really know what I'm doing, and they don't contact. So there are those individuals that are quite willing to be open and learn and get information from individuals like Dr. Grunwald, and then those individuals who say, you know what, I really know what I'm doing, I don't need to. That's where you as a parent, I think, has to step in and find the individual that will actually champion you and your child. So it's about finding those champions that are interested, and not everybody is. And if you have the sense that they are not going to be your champions, find somebody who will be.
That's correct. It's a rare disease, and I tell my medical students and the fellows and the other physicians, and we are large departments, 300 anesthesiologists, that in our great medical school, every year, 265 new graduates go out to the world. They may know nothing about FOP. They may be very active specialists in whatever field they will be for 20, 30, 40 years without seeing a single patient or hearing about FOP. So we became a center to promote the knowledge and the know about FOP. So when we have surgery in the operating room, it's look like a bazaar. Medical student, resident, fellow, physician, everybody wants to come and see, which is great, because when they are done and they go to wherever they go, they become the excellent ambassadors of you. And it perpetuates. And now when everything is actually, we've been to Africa, we've been to places in the world, they don't have a home, they barely know what the next meal will look like, everybody has a phone. So what we talked among ourselves, the ICC members, how we can promote the notion and getting out the knowledge that this disease exists. These are the challenges. And this is the list of individuals or centers that you can go and ask and seek an answer. But as Dr. Clive Friedman stated, and it's happened not infrequently, that you get a message and you receive a phone call from a team that want to help. Was a young girl, needed surgery in the Andes Mountains in Peru. So when we talked, it was clear that there was no professional knowledge at her level that could provide the care. So we escalated the care, and she has to travel until she went to a university hospital, taken care of, and she's fine. So it's not only the willingness, but you have to be your own ambassador and your own coach and lead the process and find the right person, the right team, the right institution. And sometimes when I talk to the anesthesiologists, it's not they are not willing, they admit the challenge is beyond the scope of their expertise. And they happily can recommend the next hospital, the next university hospital, or whatever. And sometime, and it happened many times in Europe, that it's not a university hospital. It's a good team of doctors and nurses. And after we have a few sessions, they take excellent care of the patients. So you don't need the ivory tower stamp. You just need good doctors and good nurses. But you have to champion the effort.
Every year I teach residents for a local hospital in the virtual system in New Jersey, and the first thing I always talk about is FOP. And the director always says, well, why don't you just talk in general about special needs? And I do that as well, but the bulk of it is FOP. And I said, well, the reason for that is knowledge is power. And if you can handle the FOP community and you understand the disease process there, then you can understand everything else, because you guys have such complexities, as you know, and it's a lot more involved. And I feel like if you have the awareness of FOP, then special needs, I mean, each one is individualized, but it gives you that awareness, and knowledge, like I said, is power.
So as I mentioned, it goes beyond just the scope of you have to be sick, it's just being the awareness about FOP to the big community. And I think that Chris Scott in South Africa talked to a patient, and they had maybe a 15 or 20 second clip, and were able to go to a third-degree radio station or TV station. It became viral. And then it perpetuates, and everybody talks about it. So, yes, now we're learning how to approach and how to go out to the community at large and bringing the knowledge about you and just to learn about. And I think the movie that Amanda created will be another very important step. So as you see, we're working on the forefront, trying to bring it to the society. And if there is awareness, there is understanding, there is a resource allocation, and we can eventually contribute to the well-being.
Good morning. My name is Dagmara. So I do have jaw fixation, and going back to the question about oral hygiene, I only have like my wisdom teeth out in the back, so I don't have many gaps like in the back of my jaw, like teeth removed. How do you, or are there things that you recommend to like brush the inside of your mouth? I do have an overbite. I'll be seeing you guys tomorrow, so we could discuss further, but it just came to my mind now. Like how to properly brush the inside of your mouth, or like are there any like mouthwashes or anything you guys recommend?
I'm actually sorry, I didn't quite get the full question. Can you repeat the question for me?
Yeah, so like, do you recommend any oral care products or any tips to like brush the inside of your mouth properly with jaw fixation?
Can I repeat what I understand? You're
Yeah.
fully closed. Do we have a recommendation on how to get the inside of the mouth cleaned? Is that correct?
Yes.
It's a tough one. Again, it depends on access. Do you have all of the back teeth? Do you have any access to that area? If you have all the back teeth and you have no access to that area, your best, it's going to be dependent on the amount of space between your teeth, and sometimes you have to access that area from the buccal aspect or the outside aspect and there are different kinds of picks that you can actually do going through the interproximal or the area between your teeth is one way of doing it. Doing a mouth rinse is another way of doing it. Making sure that you don't develop calculus on the inside is an important one. Calculus is when the plaque in your teeth is not removed and it becomes calcified and you have that very hard substance called calculus. And if you have that on the inside of your teeth and it gets loose and you've got a completely closed mouth, then the possibility of aspirating that becomes really problematic and then you get an aspiration pneumonia. So keeping that clean is really essential. Sometimes having more professional cleanings is what you need. So I do have individuals that I see not every 3 months, but I see them every 6 weeks. That enables me to actually keep that area clean enough so that you can do daily cleaning. And sometimes it takes the professional because we have certain kinds of tools that will actually vibrate that out and be able to suction it out at the same time that you don't have. So it's again individually it's an individual requirement that you and your dentist should actually have a look at what are the possibilities for you individually with your circumstances that can do that. And I would need to actually have a look and see what the possibilities are and then give you the choices of what you can do or not do. I'm not sure if that helps at all.
Okay, thank you. And then I will be meeting you guys tomorrow so we can discuss further.
Okay, great.
Thank you.
Other questions? I have a question. I know that you talk about dentistry for special people. Are there websites for people who specialize in that practice that they can find, maybe start as a place to find dental care in their hometowns?
Actually, there are websites where you can do that. So there's the place that I would start. there are actually 3 places that I would start. If you're American, there's a website called Special Care Dentistry, and it actually will identify individuals who are specialized or have a particular interest in treating individuals with special care. And even though if they've never seen a patient with FOP, they are individuals that will be interested to actually look up that material. So for North Americans, especially if you're an adult, Special Care Dentistry. If you're a child, you might be better off going to the Academy of Pediatric Dentistry website, and there you will find individuals who you'll be able to locate. And then if you're from an international audience, then going to the IADH website, which is the International Association of Disability and Oral Health website, there are areas that you can find the individuals. If you've gone to any of those and still are unable to locate someone, absolutely contact myself, and I have connections all over the world and will help you find someone who can do that. And a really good example is last year in Baltimore, we had a little young boy who had extensive dental disease. Mom had not been able to find that treatment. They're from Mexico City, and I found a pediatric dentist that was able to treat that individual completely, and actually has become a champion for working with individuals with FOP because she got so excited about actually working with individuals. She presented that case at an international meeting in Cancun. So oftentimes individuals who don't know anything about it become really keen on saying, oh, wow, this is an area that I can really work and help folk with FOP. I'm not sure if that's helpful for you, Michelle.
No, that's super great. We'll probably put that out on social media and on our website. And next year, the family gathering's in Dallas, so we should invite that dentist.
The website is scdaonline.org for the Special Care Dentistry.
scdaonline.org.
And I'm actually a fellow for them.
Okay.
And Dentistry for Special People, just so you know, they actually refer me a lot of the patients. They only treat autistic now at this point in time for whatever reason. So just so you know. They kept the name. Dr. Nussbaum coined the name.
Okay. Other questions? Yeah.
So my name's Patty, and I have Emma, who is 30 years old. She's not in here. Emma's mouth is very crowded, and she has 5 wisdom teeth that she has still never had a tooth removed.
Can you speak up? We cannot hear well here. Thank you.
Okay. So Emma is 30 years old. She has a mouth full of teeth. She still has a lot of mobility in her jaw. And we're faced with that decision of when to have some teeth out. And how do you take out teeth after the jaw has flared and it's closed? I guess I don't understand how you go in to the back of that mouth and take out wisdom teeth later on.
So what I'm understanding you asking is when one is completely closed down, how do you take the teeth out?
Yeah.
There's a good number of individuals who actually are needing that done. The only way to do that is under general anesthesia. Yesterday I heard that a oral surgeon had told the patient that the only way that I can do that is breaking the jaw, and I just about fell off the chair because that is absolutely wrong. The procedure that you actually do is under general anesthesia, very carefully, as Dr. Grunwald has spoken, and it's a possibility where you actually go in through the side and actually remove the teeth that's required, and it's done by somebody like Dr. Desidue, who who is well versed in the technique, it is not a particular problem and can be done with actual relative ease. The problem is not the surgical procedure, as Dr. Grunwald says. The problem is the anesthesia. And once you have the anesthesia done, then removing those teeth under general anesthetic is not particularly problematic. I'm not sure if that particularly answers your question, but from a surgical procedural process, it can be relatively easy to do.
I've been in many of those procedures with Dr. DeSigiu and Dr. Grunwald, and typically what they do is they section the tooth with a handpiece, and then they bring them out in parts. And then they check to make sure they have it all, and that's usually how they do it. It sounds harder than it is, but like he said, it's mostly the anesthesia that you want to be more concerned with than the actual tooth extraction. But when you're closed, typically you take the tooth out like this, so that's why most people can't wrap their head around it. But I've seen many, many cases, fuse shut, take the cheek back, go in on the side, and bring them out in pieces. It's not that difficult as it sounds. It is not that difficult.
Is it more of a trauma to the jaw than just taking the teeth out without having?
Not necessarily, because when you take a tooth out with just the normal way of pulling it out, you go back and forth, and there's a little bit of wiggle nature to the bone. Well, obviously we don't want to do that with an FOP patient, so cutting it out is actually less traumatic because you're eliminating that wiggle to the bone portion of it. Does that make sense?
Yeah.
Okay.
Thank you.
Hi, I'm Leah from Australia, and obviously having the specialist here and learning all about FOP has been absolutely extraordinary. The question I have a little girl who's 2.5, so her teeth will be coming out. I have a two-part question, that is, the teeth that come out that we have, is it useful for FOP research? And how do I get that across to you, being from Australia here? We can speak about that later, obviously. I've seen some, I guess, guidelines on saving that tooth, sending it through. The next thing is the eruption of new teeth. In an FOP patient, is there any concerns that I should have, or is it just like anyone else, the eruption of new tooth through the gum?
Great question. So in terms of the biobank, that's a question that is absolutely fabulous. Teeth that fall out, get them to the biobank. Michelle, I think you need to answer the question with respect to the mechanism by which people from outside of North America can do that and send it to you. So I'm going to leave that one to Michelle, but absolutely, if you get an exfoliated tooth, send it to the biobank. That is phenomenal, and I think FOPA would be very grateful to you for that. Your question with respect to erupting teeth is also a good one, especially since teeth erupt into the mouth, and when they erupt into the mouth, you can have a fair amount of pressure on the eruption, and you can also have localized inflammation around the tooth, and that's what normally causes the sensitivity or pain. The way to minimize that risk of inflammation around the tooth is to actually begin fairly vigorous massage and cleaning of the gum tissue prior to the tooth even coming in. And the more techniques that you use, especially say in babies before the teeth have come in, where you are developing a much harder gum tissue, if you will, by using as many different textures as possible to rub and clean the gums, you will minimize the impact of the pain or the eruptive inflammation around the tooth as it is coming in. So that would be the same information that you would do on a baby as it would be on an older adolescent, where you're permanent teeth or your wisdom teeth are starting to come in. It's about keeping it as clean and as firm as possible as you can.
And I will get you connected to Adam Sherman to answer your questions about the biobank. It's definitely more difficult, but if we're prepared, it might be able to work. So, yeah. Okay. Any other questions? This has been super helpful. Okay. Well, thank you to our panel. We appreciate the way you care for our patients and that your willingness to come and spend time here answering questions, in these group settings, but also spending time in the dental clinics as well. And it's an important issue to the IFOPA, and we continue to investigate ways that we can continue to serve the community in this area as well.